Welcome back to Anesthesia series. Today we are going to tackle neuraxial anesthesia. So in the objectives of today's class, we are going to define neuraxial, benefits of regional anesthesia, vertebral anatomy and the ligaments that support vertebral column, spinal anesthesia and its complication, epidural anesthesia and the differences between spinal and epidural anesthesia. So the introduction. What is neural anesthesia? Neural anesthesia is a regional anesthesia technique that involves injection of the local anesthetics into fatty tissue that surrounds the nerve roots as they exit the spinal cord. So it could be either epidural or caudal, or into the cerebrospinal fluid that surrounds the spinal cord, that is spinal anesthesia. So the neural axial techniques include spinal anesthesia, epidural anesthesia, and combined spiral epidural. So neural anesthesias usually inhibit sensory, motor, and autonomic function at the level of the nerve root. Benefits of regional anesthesia over general anesthesia include decreased risk of aspiration or respiratory complications, reduced risk of bleeding from the operative site, faster return of GI function, less incidence of nausea and vomiting, usually preserve the protective airway reflexes, and through that we have decreased risk of aspiration and respiratory complications, decreased incidence of deep venous thrombosis. It is usually cost effective and usually have better pain control postoperatively, and usually we have low incidence of cognitive impairment, reduced stress level to surgery. So neurolaxial anesthesia, before we go to contraindication, this is in the injection of local anesthetic into the subarachnoid space and epidural space. So briefly, this is spinal anesthesia and epidural anesthesia. So what are the contraindication? We will divide them into two, where we have absolute contraindication, and the first is usually patient refusal. So when the patient refuses to have neural axial anesthesia, you take it as an absolute contraindication. Infection at the injection site, and the reason behind this is because you are going to predispose the patient to having meningitis among infection to the central nervous system. Coagulopathy and bleeding disorders, this patient could result to spinal hematoma or epidural hematoma. Uncorrected hypovolemia, one of the complication of the spinal anesthesia is usually hypotension, and the reason behind this is because of the blockade of the sympathetic nervous system. So if you give neural axial anesthesia to a patient who has uncorrected hypovolemia, it could worsen the situation. Increased intracranial pressure, aortic or mitral stenosis, and local anesthetic allergy. So relative contraindication include pre-existing neurological deficits. When you give neural axial anesthesia, it could exacerbate the existing or pre-existing neurological deficits, congenital or acquired abnormalities, and post-traumatic vertebral injuries and sepsis, which will result to more. So spinal anesthesia, this involves the injection of local anesthetic into the subarachnoid space, and this one usually produces a reversible loss of sensory and motor function. Kindly note, not only sensory and motor function, but also autonomic function. So it produces an excellent condition for surgeries below the umbilicus. So it is used for, so if below umbilicus, so we'll have procedures that are obstetric, gynecological, urological, lower abdominal and perineal, and lower extremities surgery. So the examples of the surgeries include inguinal hernia repair, hemorrhoidectomy, anal fissure, cesarean section, abdominal and vaginal hysterectomies, transurethral resection of the prostate or the bladder tumor, lower limb surgery that including the orthopedic, vascular, and plastic. So the spinal cord of a human being usually ends at the L1. So L1, whereas for an infant usually ends at L3. This is very important because as you have said that the spinal anesthesia will inject the local anesthetic into the subarachnoid space. So if you have to inject, you'll have to inject below. If for an adult, you'll have to inject below L1 or L2. So that is L3, L4, or L4. So the spinal technique, the preparation, you do monitoring of through non-invasive BP monitoring, heart rate, respiratory rate, pulse oximeters. You also give IV fluid access through running. You give IV fluid access and then you put a running IV fluid. And then you do preparation for general anesthesia, that is airway support if required. And the reason behind this, if you need to change to general anesthesia, then you need to be ready. And this is very important in an emergency session. So next is patient positioning. You can either position the patient in a sitting position or lateral decubitus position. So next is you identify the two first line, and the two first line, this is a line that is drawn that is between the iliac crest. So that line literally corresponds to L4 and L5. And this is important because we have said that the spinal cord usually ends at, an adult spinal cord usually ends at L1. So then you do the spinal anesthesia can be performed either at L3, L4 or L4, L5 interspace. Layers traversed by the spinal needle include skin, we have subcutaneous tissue, and then we have supraspinous ligament, and then we have intraspinous ligament, and then we have ligamentum flavum, as you can see here, and then we have the epidural space, and then we have the dural matter, and then we have arachnoid matter, and then now we have the subdural space. So the complication of spinal anesthesia include, the first one is hypotension, and this is the most common complication due to spinal blockade. As we said before we started, that spinal anesthesia blocks the sensory, the motor, and the sympathetic. The next could be bradycardia, nausea and vomiting, itching, shivering, short-term hearing loss, high spinal or total spinal, urinary retention due to blockade of S2, S3, and S4, postural puncture headache, infection, that is meningitis, epidural abscess, neurological complications such as coda inguina when you injure the spinal cord. You can also have direct needle trauma to the spinal cord. So let's briefly look at the pathophysiology. Postural puncture headache usually results after you've given, it's a complication of spinal anesthesia. So when you give spinal anesthesia, you usually inject local anesthetic into the cerebrospinal fluid in the subarachnoid space. So this will result when you are going in through, you'll have to puncture the dura mater. That's why the disease is called postduro, meaning after you've punctured the dura. So after your puncture, the dura will result to cerebrospinal fluid leak, and this cerebrospinal fluid leak will result to decrease of the CSF fluid pressure. When you will have decreased cerebrospinal fluid pressure, will result to vasodilation of the cerebral blood vessels, and this therefore will result to the postural headache. So the postural puncture headache, as you mentioned before, it usually results from a disruption of the normal CSF homeostasis due to persistent leak of CSF. So the onset is usually within 12 to 48 hours after the spinal anesthesia, and usually rarely after 5 days. So the headache is usually postural headache that worsening when you are standing upright in an upright position. And the reason behind this, when you stand in an upright position, you're going to decrease the pressure in the CSF, therefore increasing the dilatation of the cerebral blood vessels, and is usually relieved while lying down. So the headache is usually bilateral, and that is the bilateral headache that is frontal, occipital, or both. And the character of the headache is usually dull, aching, or throbbing, or the patient can say that he or she is feeling pressure. So the severity can range from 1 to 10 on the 10-point pain scale, and the associated symptoms include nausea, photophobia, tinnitus, and neck stiffness. So the management of postural puncture headache is usually resolved on their own. However, you can give the pain management by giving NSAID, paracetamol, opioid to manage the pain. Other pharmacological therapy usually include methylxanthines, EGOT, alkaloids, corticosteroids, serotonin type 1 agonist, and the definitive management is usually epidural patch. Epidural anesthesia, this is a central neuraxial block technique with many applications. It can be used to provide surgical anesthesia for operations involving the lower abdomen, pelvis, perineum, and lower extremities. So additionally, it can provide anesthesia for procedures including lower limb, as we mentioned, pelvis, abdomen, thorax, and for labor analgesia. So epidural space is identified through the loss of resistance technique. We are going to, there's a table on the differences between the epidural and spinal anesthesia. So the advantages of epidural over spinal anesthesia is the ability to maintain continuous anesthesia after placements of an epidural catheter, and this making it suitable for long procedures. The contraindication and the complication are similar for the ones of spinal anesthesia. Differences between spinal and epidural anesthesia. Spinal anesthesia, the injection is in the subarachnoid space, and through this we have to puncture the dura mater. So whereas extradural anesthesia, the injection is in the epidural space, and this is between the ligamentum flavum and the dura mater. So meaning we don't have to puncture the dura mater. So the spinal anesthesia is between the level where we inject the needle is below L1 and or L2 where the spinal cord usually ends, whereas in extradural or epidural anesthesia, it's usually at any level of the vertebral column. So the identification of the subdural space in spinal anesthesia is when you see CSF appearing, whereas in epidural space, how do you identify the peridural space is using loss of resistance technique. So the dose of spinal anesthesia is usually uh, less, that is 2.5 to 3.5 ml of buvucane, and then in extradural or epidural, the dose is usually 15 to 20 ml of buvucane. Whereas spinal anesthesia, this is very key that the onset of action is usually rapid, that is 2 to 5 minutes, whereas the onset of action of epidural is usually slow, that is 15 to 20 minutes. So the spinal anesthesia, the density of block is usually more dense, whereas in epidural, the density of block is usually less dense. So side effects of neuraxial anesthesia include hypotension, and in spinal anesthesia, it will be rapid, whereas in epidural anesthesia, it will be slow. Another side effect is headache, and this one is usually caused because of the leak of the CSF. And kindly note, in spinal anesthesia we have leak of CSF, so this will be a complication. Whereas in epidural, it is not a complication because we don't puncture into the cerebrospinal fluid.